These are the current episodes that are on the street, if you will. Hip replacement, I said, perinatal pregnancy, colds, heart failure. That's a hospital is the PAP, and ADHD, which is a fairly complicated one for psychiatrists, PCPs, and psychologists. What we do is we give people a chance. They get the report cards. In tonsillectomy, it would be given to you in April. Those are basically preparation report cards. We gave all the current wave of episodes their preliminary report cards in August and gave them a 3-month window to begin to adjust their practice style so that, technically speaking, as we move forward, even though you saw in that graphic that if you could be at risk for 50% of the overage, the program is established so that if the whole curve moves to the right, you can have nobody in the high risk category where they have to pay back, and we could be paying bonuses to people. We're hoping everybody improves over time, and that we don't have to have anybody at the at-risk group, but instead everybody moves toward the gain sharing route, and the program is designed so that if everybody becomes more effective, there are no penalties, if you will, and there'll be many people in gain sharing. And so that's what we're doing here. They'll have a 3-month window before the episodes, if you will, count. And during the year of the episodes, you will get quarterly report cards that shows you where you are, how you're performing, and how your cost profile is doing as the year progresses. So the big picture here is tonsillectomy, adenoidectomy. Most of the time, the patients are being sent to an ENT from a primary care physician, probably a pediatrician, family doc, and there are all sorts of ways it goes through. Most of the time now, this is done as an outpatient. Many times it's a same-day recovery. There'll be some higher risk patients, or some patients may have a slower recovery time. They may have to need longer observation or overnight observation. There are issues of complications, potential bleeding. There are a variety of risk factors involved, but for the most part now, there is a pre-procedure workup that may or may not use a sleep study. Again, depending on the complications or the comorbidities of the patient. And so there are all sorts of choices in that regard in terms of the overall impact of the elements that go into the episode for care. Some patients who are higher risk may require more workup, and again may require longer recovery time, and we'll try to work that into the risk factors for designing the average cost per episode.
So I'm on page 21 right now, which gives a summary of the number of cases for this episode across two of the payers, Medicaid and Blue Cross. So on the left-hand side, you'll see that the total number of adenoidectomies, tonsillectomies, and adenotonsillectomies were a little over 4,500 for Medicaid over the course of a 12-month period. The majority of those were adenotonsillectomies, at about a little bit over 800 of the adenoidectomies, and then a smaller number, 380, just tonsillectomy alone. And for Medicaid during this 12-month period, there were 64 providers, ENTs, that were performing the procedure for these 4,500 episodes. So the left-hand side is the Medicaid data. The right-hand side is the Blue Cross data, so 1,300 total procedures, total episodes, 175 adenoidectomies, and you can see the additional numbers there, with 75 providers performing these procedures. So I'm going to go through now, starting on page 23, some of the proposed, or the version 1.0, so to speak, episode design. I'll walk through the details so you have a sense of what's in the episode, etc., and then I will again pause for questions to invite discussion from the group. So if you can all turn with me to page 23, just walk through the different components of episode design. So in the first bucket, what's the scope of services, the episode definition. So the episode, which includes both tonsillectomies, adenoidectomies, adenotonsillectomies, is triggered by any of those three procedures I just mentioned, and where there are primary or secondary diagnosis codes of those that you see listed here. So that triggers the episode. That's what led to the counts on the previous page, the 4,500 or so for Medicaid as an example that we just walked through. And you can see some of the diagnoses include chronic tonsillitis, chronic adenoiditis, etc. I will also clarify that for this episode, we're only talking here about tonsillectomies, etc., that started in an outpatient setting. Those that were performed started in either the ED or inpatient setting. It's a very small percent of those that we're seeing. Let's say those are excluded. They are not part of what we're discussing here. They're very different, very different contexts. In terms of the episode time frame, we had a lot of good discussion, debate, input from our clinical advisors on what goes into the episode, when it starts, how to think of a pre-procedural period. And here is where we landed. The episode starts, basically, if you think of when the trigger, when the procedure happens, there's a 90-day look-back window, but the episode starts at the time when we find the first claim, the first visit for the performing provider. So in this case, it would be typically the ENT. So let's say someone performed a tonsillectomy on January 1st. Basically the payers would be looking back 90 days, and if a particular ENT saw that patient December 10th, the episode would start December 10th. So roughly 20 days before the start of the procedure. If someone saw that patient on December 31st, the episode would start then. So there's a variable window length at the beginning. In terms of the services that are included in the pre-procedural period, it's basically all related services identified primarily through relevant diagnosis codes that happen during that window. So again, all those services all occur after the patient has the first visit to the ENT. The episode then continues for 30 days after the procedure, and related services are all included there. Again, identified primarily by diagnosis codes, but that includes inpatient and outpatient facility fees, any related professional claims, diagnostics, medications, and things of that sort. Inpatient post-procedure admissions within 30 days of the procedure are also included, we've applied the CMS exclusions, typically from CMS, of what types of admissions, if there's an accident of some sort, those would not account toward within the cost of the episode. One other note here, RX, antibiotics as an example. RX in the pre-procedural period is not included. So if an ENT, schedules a patient 3 months out because they're at school and something like that and has to manage in between with antibiotics, the cost of those antibiotics are not included in the cost of the episode. Antibiotics and RX are included in the 30 days after the procedure happened. So I just want to make that very explicit as well. Continuing on, and again, I'll walk through the overview of this and then pause. In terms of patient and episode exclusions, so Bill mentioned at the upfront there are a number of things to really exclude episodes and patients from the cost calculations here to make sure that we're looking at a fair sample. Exclusions include a number of select comorbid conditions. These would be, you see an example list here, but any of these that basically occur the most by 365 days before the procedure. If the payers find that sort of claim, that sort of comorbidity, that episode, that patient is not included when the payers are calculating the average cost per episode for every principal accountable provider. Certain other things like UPPPs on the date of the procedure, where there is a patient that has that in conjunction with tonsillectomy, those patients are also excluded because it's a very different context that we're talking about. In addition, patients with a BMI over 50 be excluded. In this, we had feedback directly also from the clinical advisors for that. You'll see also that this version of the episode is only focused on patients between the ages of 3 and 21. on episode adjustments, again, as Bill mentioned, as Dr. Golden mentioned, there are going to be a number of risk factors that adjust the cost of the episodes and what the thresholds would be to account for different severity levels. Those would include things like diabetes and other conditions, a number of comorbid conditions. And there are really going to be two episode types within this episode. One is adenoidectomies, and the other type is tonsillectomies and adenotonsillectomies. The latter, the costs and the profile for those two are very, very similar, and so those are going to be grouped into one sub-episode. In addition, only providers with at least 5 episodes per year for each payer are going to be eligible to participate in gain sharing or risk sharing. So that's the set of episode adjustments. There are a number of quality metrics as well. And as Bill mentioned, there's some quality metrics that are going to be required for reporting and to hit, a minimum level to be eligible for gain sharing payment. And there's really one of these here that we want to talk about a little bit too, which is the percent of episodes that have the administration of an intraoperative steroid. There are a few other metrics that are going to just be reported only. They're going to be on the report card, so every one of the principal accountable providers can see what the performance looks like. But those are going to be postoperative primary bleed rates, postoperative secondary bleed rates, and the rate of antibiotic prescription post-surgery is going to be another metric. That one is we would invite feedback on as well. That one, there are guidelines actually suggesting that should be at a lower minimum or smaller number for these episodes. And finally, for Medicaid, for the principal accountable provider, that would be the ENT or the provider that is performing the procedure. And I think Blue Cross and the other payers would make decisions in the following time periods as well.
On page 23, with regard to exclusion criteria, severe asthma is one of the exclusion criteria. How do you determine the severity of the asthma that would be factored in there?
So their diagnosis with asthma with acute exacerbation, so it will be based on ICD-9 codes.
You see here starting 90 days pre-procedure. This is really up to 90 days pre-procedure, but really starting with the first visit to the ENT or to the performing provider. That is when the episode starts. And I do, again, want to just call out that the claims in the pre-procedure window, based on a lot of feedback and discussion, working sessions we had with our clinical advisors, includes only related services after that first visit with the ENT. All the episodes that have been launched to date, you can go on to the payment improvement website and see all the detailed codes and ICD-9 CPT codes that are relevant. I'd actually like to invite our 3 clinical advisors up here, because we had, in all of the episodes, cholecystectomies, tonsillectomies, hair colonoscopies, we've had a lot of feedback and discussion about what is the appropriate pre-procedure window, because there's questions of you want to capture the right set of services in the pre-procedure window. You want to incent and reward coordination of care, but at the same time recognize what a principal accountable provider really has control over or not. And so I'd invite any of the 3 of you just want to comment on some of the discussions that we had, some of the concerns that were raised, and how we ended up at this particular proposal.
There were several challenges in this, and it was what was described to the principal and provider. One of the big questions was the question of a sleep study, whether a physician outside the ENT had ordered a sleep study within a 90-day time window. The ENT had no authority over whether we should control that, and right now our answer is no. However, many physicians will want sleep studies during that process, and if a physician ENT orders it, they should be accountable for it. The exclusion should include many of the patients by standard criteria that would require a sleep study, which is one of the added costs. It's a fairly significant added cost. This algorithm as it exists probably will pick up most of the patients that are going to go through standard algorithm, see a physician, get surgery, and be finished on a fairly reasonable basis. There are other episodes that may happen related to this that are less common, but certainly possible. Episodes of tonsillitis could happen. Sleep apnea may have some exacerbation that requires intervention, but that should be fairly uncommon, as most of these surgeries are done on a fairly timely basis.
So the bottom line is we're going to exclude everything that's complicated, and all we're going to evaluate with this episode is the routine tonsillectomy. Anything that is going to be out of the norm, done in children's, if you're doing a Downs child or craniofacial deformities, we're going to take that out. There's no telling how long they're going to have to stay in the hospital, no telling how frequently they might have to be readmitted. We're just going to look at the episode basically just covers routine tonsillectomies, and it starts with that ENT physician and what test he orders. If he decides he needs a sleep study, he has to know that's going to be part of it. And studies show that the value of the sleep study is not that great. It's more of a clinical diagnosis.